So today, overview about Microport pacemakers. The name have been changed consistently over the last years. First, it was Ela Medical. It was a French company. Then it became Sorin, an Italian company. And then Livanova, American company. And now it's Microport. And Microport is Chinese. So this is the first screen here. When you interrogate a dual chamber pacemaker, and like in all the other pacemaker, do you see my arrow here moving? Yes. Okay. So what we have in this first screen are the main information. First, warnings and observations. For example, if you have the patient had episodes of atrial fibrillation, other important information, I would say. Then the system status. So you see here, it's more or less the same that for all the other company. Before the time duration before RRT was based on the impedance, and in this new platform, this is an Alizea, so a very new Microport pacemakers. Now it's based on the voltage, so the duration will be based on the voltage. And what can I say? The magnet rate when it's new is 96 beats per minute. When it's RRT, is going to be 80 beats per minute. The thing important to know is that anytime you will reach the RRT, there is a modification of the pacing rate and the pacing mode. In this patient with a dual chamber pacemaker, when you will reach the RRT, there are going to be a shift from DDD or AAI safer. I will explain what is this specific mode, to VVI. And the rate will be modified. The minimal heart rate will be 70 beats per minute. So you can reprogram the device. If the patient has reached the RRT, you can reprogram, but every night the device will come back to VVI 70 beats per minute. I think this is something important to know, since I don't, in our center at least, we do not wait the device to reach the RRT, because some patient may be symptomatic at this time, if, for example, they have a retrograde conduction. So this is a specificity for Microport. Remember that when you reach your RRT, there's going to be a change in the pacing mode and the pacing rate in VVI 70 beats per minute, and some patient may be symptomatic. That's the reason why we try to change the device systematically before reaching the RRT. Then you have the information about the leads. So this device has been interrogated the 24th of August. So you see the last measurements. Now everything can be automatic. You can have, of course, measurements of the P and R waves, but there's now in these devices automatic threshold at the level of the ventricle and the atrium, and you see the last value for the ventricular thresholds. It's automatically measured every 6 hours, and for the atrium it's once a day. Okay, so this is the last value, and you see also the measurements of the impedance at the level of the atrium and the ventricle. On top, on the right, you have the parameters, the main parameters. So you see here this pacing mode. If there is something to know, this is this mode, and I will try to explain the specificity of this specific mode, which is called Safe RR. I will explain what it is exactly. And you can see the main parameters that have been programmed, and then you can see the statistics. So it's clearly the same that for all the other devices. You see that this patient has been implanted for sinus node dysfunction. So it's functioning with a safe R, and the patient is paced a large amount of time, 84% of the time at the level atrium, and it's sense, which is the idea of this pacing mode is to respect the entrancing conduction. So the patient is sense, and 99% of the time at the level of the ventricle. Briefly, if you click on diagnostic AIDA, here this is where you will have the informations, and You see here in summary the heart rate, the pacing percentage, the time in atrial fibrillation. What is important here, it's like this, it's the same that for Boston Scientific. There are two sensors in Microport devices for the rate adaptive function. You can have either the accelerometer or the ventilation minutes. So you can have separately or functioning together. But since there is the possibility to measure the minute ventilation, then you may have information about sleep apnea. So that's something here, and you see the results here. The line is the limit that is considered to have something significant in terms of sleep apnea. So if you program this sensor, the ventilation limit, then you can have this information. And clearly, in some patients, that can be very interesting for initial diagnosis and then you will require, of course, a confirmation with a polysomnography. But first, just on a large scale, all the patients implanted with this kind of devices, you can have an idea if there is or not any sleep apnea. Okay, now if you click on PM, I will show you briefly how to interrogate, but you can see the heart rate. So I will systematically have a look to this to see if there is an acceleration, and you can see the rate for the last 7 days, day by day. You can see the different information day by day, and you see that there is an acceleration or not if the patient is sense or pace at the level of the atrium. If you click on auto sensing, this is specific to Microport, and I will show you with another patient that can be very interesting in some specific patients. This is the repartition. You click on R wave, please. Also, you see every bit. The amplitude of every bit is measured, and you will see, and I will show you an example where it can be very, very interesting to have a look to this. And you see here the amplitude of the signals, the R wave, and the PVC. If you click on statistics, of course, you can have the percentage of pacing. This is where, if you want to know if there has been some episode of PMT, that's here. See here, it's 0. You will see if there have been some switches, if there have been some episode of atrial fibrillation. This is where you can find all these informations. For all interrogation, I will click on all these things. For example, auto threshold curve, if you can click on it. You see here the measurements in terms of the thresholds at the level of the atrium and at the level of the ventricle. So I will just show you briefly this information. If you click on
the background check. Thank you.
Sorry. If you click on AV conduction, please. AV conduction. I will, on the next case, I will show you. That's, I think, there have been a lot of work in Microport devices about this specific mode, the AAI safe air, which has been developed to decrease as much as possible the percentage of avoidable right ventricular pacing. So in case of, for example, sinus node dysfunction. And I think this is where you can have most of the information compared to all the other competitors. I always start with this table. You will see, I will explain you that there are 4 parameters for a shift from AAI to DDD. The pause, the AVB1, AVB2, AVB3, so atrioventricular block, first degree, second degree, and third degree, and pause. And you can know the numbers of episodes of shifts from AI to DDD at rest, during exercise, the day, the night, and I will show you how it works. So now if you come back to the parameters, so as I said, if you click on the modes, please. This is something important. The safe R means this is an algorithm that I will explain and design. It's AAI to DDD. And if you want to have a rate adaptive function, safe R is without rate adaptive function. If you want the rate adaptive function, then you need to program the safe R. Okay. Well, For all the other parameters, I think that's it quite standard, the same that for all the competitors. Now, if you click on the rate, something specific, you have the basic rate at rest and the max rate. This is something very specific to Microport. The rate adaptive function, the maximal tracking rate and the maximal rate during rate adaptive function is the same. You cannot program them separately. You just program one. So if max rate is for both maximum tracking rate and rate adaptive function. Okay. Now some details. The sensitivity initially on the previous devices, all those devices, the nominal value was 1 millivolt at the level of the atrium. And in this platform, it has been modified to 0.6 millivolt. I think it's a good idea because sometimes at 1 millivolt, it was not sensitive enough to detect, for example, atrial fibrillation. It has been also modified at the level of the ventricle. It has been on the Alizia, it was 1.5, and now it's going to be 2.5 because 1.5 was a bit, was probably too much, too sensitive in pacemakers. For the auto sensing, if you click on it, yes, auto sensing, you know that in all the other competitors, you have the choice. When you program the sensitivity, you have the choice between a fixed sensitivity and what we call an adaptive sensitivity, like in an ICD. Okay, and remember that in Microport, it's always a bit different, but in this case, it is different. You have the choice between auto and monitor. If you program monitor, and that's what I usually program in most of the patients, it's going to be a fixed sensitivity, so monitor with repetitive measurements of the amplitude of the signals. So you will see the results in terms of detection in the curves and in all the parameters that I have shown you. If you program auto, consider that this does not function like in an ICD. Auto is different in a pacemaker, in an ICD. The idea is that it's a bit complex, not too much, but a bit complex. You will measure the amplitude of 8 consecutive cycles, and you will adapt the level of sensitivity compared to the 8 measurements, but the sensitivity will be fixed during the cardiac cycle. Okay, it's not an adaptation during the cardiac cycle. What you will change, it's going to be, it will remain a fixed sensitivity, so stable during the cardiac cycle, but the level of sensitivity will be modified according to the amplitude of the signals. I'm not very convinced, to be honest, about the interest of this. So most of the time, not to say in all patients, I program its monitor, it's going to be fixed, remain at the same value, and you will have systematic measurements of the amplitude of the signals. What has been modified also is the auto thresholds. If you click on auto thresholds, you have 3 choices of auto monitoring. If you program it off, there's not going to be any measurements of the thresholds. And so you will not see, when you interrogate the device, any measurement of the thresholds. If you program it on monitoring, then there's going to be a systematic measurements of the threshold every 6 hours in the ventricle, once a day in the atrium, but without adaptation of the amplitudes. If you program it on, click on it on auto, then you will have an adaptation. So systematic measurements every 6 hours in the ventricle, once a day in the atrium, but with adaptation of the amplitude. Remember that Microport is about the same than Medtronic. Microport and Medtronic are more or less the same for the auto threshold. It means that there's no verification cycle by cycle about the efficacy of pacing. This is the name, it is an auto threshold. So, for example, at the level of the ventricle, measurement every 6 hours, and then according to these measurements, there's going to be a margin You see now, in this new platform, you can program the margin. You can modify the margin. You see, 2 times the threshold, 1.5 the threshold, 2.5 the threshold. Okay, so you can adapt at the level of the ventricle and level of the atrium, but without verification cycle by cycle about the efficacy of pacing. So at the level of the atrium, if you remember, for all 5 companies, it is an auto threshold. So it's the same for Microport. At the level of the ventricle, Medtronic and Microport auto thresholds, and the 3 other competitors, Abbott, Boston, and Biotronic, it's going to be what is called something like auto capture with confirmation cycle by cycle about of the efficacy of pacing. So if it is an auto threshold at the level of the ventricle, of course, you need to program higher value in terms of margin. So you will double the measurements, usually that's nominal. You will double the value of the measured thresholds. And you will also program a minimum amplitude. You see, it's 2.5, whatever the thresholds, for example, here, if it is 0.5 volts, you will deliver 2.5. If it's 2 volts, you will deliver, if it's 1.5 volts, you will deliver 3 volts. And there is a maximal value, the safety amplitudes, that is also programmable. Remember, you will not deliver, you can program up to 6 volts if you program it, you see, like that, but nominally it's going to be 3.5. So if you have a high threshold, do not forget to reprogram this up to 6 volts. Okay, if your threshold is, for example, 3 volts, you will have to program here at the level of 6 volts to be sure that there's going to be a capture. Okay, nothing else to say here. If you program now, Brady, please. Brady, the MRI mode, if you click on it, please, you can program it auto. It means that if you program auto for 1 day, the device will automatically recognize that the patient is inside the MRI and automatically will modify the pacing mode. And once the MRI will be finished, after 5 minutes, it will systematically come back to the what you have programmed on the long term. So that's an interest. The patient will not remain in DOO before and after. He will shift automatically from DDD to DO once the patient enters the MRI and will systematically come back to the program mode that you have, AI, SAFER, or DDD, once the patient will leave the MRI. Okay. I will explain you just after in one patient's all the parameters. The SAFER is something important that you need to know. So I will explain the parameters that you can program. You see the apnea. You can program it. If you program your sensor with the ventilation minute ventilation, then you will have possibility to measure the sleep apnea. You will program also a duration, and for example, from midnight up to 5 a.m. This is the time where we will try to analyze and define if there is a sleep apnea. You see, measuring the minute ventilation has the possibility to say that there is an apnea, no respiratory cycles at all, or an hypopnea if there is a decrease either in the amplitude of the cycles or in the or prolongation of the duration of the cycles. Okay, so you will have information about the sleep apnea if you program the sensor. Yes, if you click on sensor, please. Sensor. Rate response.
Les paramètres?
Oui, c'est la rate response sensor to entry. Okay, you have the G is the accelerometer, minute ventilation, or twin trace. It means that you will work with both of this sensor. Okay, okay. That's about it about the parameters. So now we will see the second case. Okay, it will take 1 minute, but what could I say? As explained, and you see that's now it's more or less the same for all 5 competitors. What you need to remember is that the auto-sensing is different. Auto-sensing is different in pacemakers and in ICD. It does not work like an ICD. I usually recommend not to program the auto-sensing on auto. And remember, at the level of the atrium and the ventricle, there is possibility of automatic measurement of the threshold. And this is an auto threshold, both in the atrium and both in the ventricle. So now it's an older device, and you see here the interrogation, and you see on the observations that most of the time this patient has been implanted for sinus node dysfunction, so is paced 99% of the time at the minimal heart rate in blue, and at the sensor rate in red, and in sense inside the ventricle 99% of the time. But you see that it's not 100% of the time. So now if you click on diagnostic AIDA, please. Diagnostic AIDA, AV conduction. So come back first to summary. You see here the information about also the sleep apnea. You see that there's not much episode of sleep apnea in this patient. So AV conduction. This, you see the first with the, okay. And as I said, you see, this is clearly the competitor with most, you have the more information about the episodes of atrioventricular block. You see the different levels at rate, at night, during exercise. So it can be interesting in some cases. So now if you look at the tracings, we'll start first. So there are 4 parameters. So if you zoom, the first one is a parameter about, you see, the first one is first degree AV block, long PR interval. So there's one criterion for this. You see in this example, the patient is paced at the level of the atrium, and you see that there is a long interval between each atrial pacing and ventricular sensing. So there's no blocked P waves. It's a first degree AV block. And in these parameters, you will program a value. I will explain how to program it. And if 6 consecutive cycles, the duration of the AV interval, so APVS or ASVS, is longer than a specific value that you will have programmed, then they will have a shift from AAI to DDD. So this is the case here. You see 6 consecutive cycles with long PR interval, and then you see at the end of the tracing, it will turn to DDD. Okay, so if you close, you see now it's in DDD. Close. The second degree AV block, increase the, okay, you see here that this is non-programmable, but if three atrial activity, either atrial pacing or atrial sensing, are blocked over 12 cycles, then it will shift from AI to DDD. You see here, first, initially, APVS, AP1 atrial pacing, which is blocked. This one is conducted. This one is blocked, conducted, blocked. So 3 blocked atrial activity. And then the patient will shift from AI to DDD. Okay, close. Then the third degree AV block. Now, it's very simple. Huh? You have 2 consecutive atrial activity that are blocked. You see, atrial pacing first is blocked, second is blocked, and then it will systematically shift from AI to DDD. And the last parameter is going to be the pause. And now this is a VVI parameters. It will analyze the ventricle cycles, and the duration of the pause can be programmed. It can be 2, 3, or 4 seconds. And you see here, the duration of the pause is more than 2 seconds. So there's going to be a shift also from AI to DDD. Okay, so 4 parameters. AV1, 6 consecutive cycles with a duration of PR interval longer than the program value. Second degree AV block, 3 out of 12. third degree AV block, 2 consecutive, or ventricular pause. So a pause in terms of ventricular activity of more than 2, 3, or 4 seconds, you can reprogram it. So if you click on the parameters, you see now on safe air criteria, you see what you can program here is the maximal pause first, as I said, 2, 3, or 4 seconds. For the third degree IV block and second degree IV block, nothing is programmable. It's 3 out of 12 or 2 consecutive. Okay. For the first degree IV block, then you can reprogram it. There are parameters that you can program. If you click on rest plus exercise, if you click on it, okay, you can program it rest and exercise or just exercise. It means that it's a bit more complex than that, but remember that what is exercise for the device is the rate. It's a bit more complex, but let's be simple, faster than 100 beats per minute. So the device will consider that the pacemaker is during exercise if the rate is higher than 100 beats per minute. So for example, you can say, okay, I will accept a long PR interval at rest, but I want a device to commute from AI to DDD during exercise only. So if you want, you can program it exercise only. Okay. So in this case, you will accept the fact that the PR interval is long at rest. And you can program the value, the long PR max and long PR mean. Long PR max is the value at rest. So let's consider you have programmed rest plus exercise with a minimal heart rate of 60 beats per minute. Then the limit for the long PR interval is going to be 350 milliseconds. And long PR minimum 250 is at maximal tracking rate, means here in this example at 130 beats per minute with a linear variation between 350 milliseconds and 250 milliseconds from minimal heart rate to maximal heart rate. And one thing also important, this value corresponds to the long value, the longest, to the limit in terms of spontaneous P waves. If you want to have the value, if you have, for example, atrial pacing and ventricular sensing, atrial pacing, you need to add 100 milliseconds to this value. Okay, so at rest, if you are atrial paced, if it's programmed like that, it means that the value for shifting from AI to DDD is going to be 450 milliseconds. Okay, you need to add 100 milliseconds to what is programmed here for atrial pacing. Okay, are there any questions here? No? Tu vas changer le cas? Ouais. No questions? I speak a lot, but if there are any questions, they are welcome. And then we will, you know, this is probably the device and the company where the idea to decrease as much as possible the percentage of ventricular pacing is the more important, I would say. Okay. The criteria for shifting from AI to DDD are more or less the same that for Biotronic. If you use the VP separation, it's about the same. So now in these patients, if you click on diagnosis AIDA and IV conduction, okay, the tracings. So if you see this example, go back at the onset of the tracing. I have shown you the criteria for commuting from AAI to DDD. Once the device has commuted in DDD, there are also 2 criteria, but just remember one. After 100 beats, so ventricular pacing, 100 ventricular pacing, then it will think about coming back and shifting back to AI. And this is where it's very different. Mets-moi le critère de pas le BAV2. BAV2. Non, remets-toi là-dessus. Come back, please. Le BAV2. So you see, after 100 bits, automatically, it will come back to AI. So you see, for example, in Biotronic, once he has commuted from AAI to DDD, then it's going to be an hysteresis of the AV delay in Biotronic. It means that If he has considered that it was an episode of AV block, the device has shifted from AI to DDD, then it will not accept any block P waves in Biotronic, because there's going to be a prolongation of the AV delay, but if there is no entrancing activation, he will pace at the end of a long AV delay. It's an hysteresis of the AV delay in Biotronic. It's different in Microport here. Remember that the criteria are more or less the same from AI to DDD in Microport and Biotronic, but once he has commuted to DDD, it's different between Biotronic and Microport. In this device, he will automatically come back to AI, and you see, then you will have to encounter once more one of the 4 criteria to come back to DDD. So in this example, you see here, after 100 beats ventricular pacing, automatically he will come back to AI, and you see here there is one block P wave. This is conducted, a second block P wave. This one is also blocked, so it's 3 out of 1, 2, 3, 4, 5, 6, 7. So more than 3 out of 12. So it will automatically come back to DDD. So remember that even if at one time it will shift to DDD, there is a risk of block P wave. So I will say that this algorithm is the one where the risk of blocked P wave is, of course, the more important. But, of course, the other way, this is the algorithm where you will have really the minimal pace percentage of right ventricular pacing when it can be avoided. Okay, so it's a balance, of course. If there was a study comparing this algorithm compared to the other one, I would say probably that this is the one where you will have the lowest percentage of right ventricular pacing, but the higher risk of block P wave. Of course, I will not give you all the details, but remember also that if there are repetitive shifts from AI to DDD, at one time it will stop searching for entrancing conduction, and it will search only once a day. If there are many episodes of DDD to AI, DDD to AI, then it will stop searching for entrancing conduction, and it will just do one search every morning at 8 a.m. every morning at 8 a.m. So let's consider a patient with complete AV block. Of course, we will not program the ASFR. Of course not. There's no reason for that. But if you program the AI SFR in these patients every morning at 8, then you will encounter block P waves at this time, but only once a day. Okay. Any question? Hugo Pierre, are you there?
Yes, I'm there.
You are there. Cool. So go on diagnostic AIDA. You see that, come back to the overview, please. You see, this is a patient with sinus node dysfunction. You see 99% of pacing at the level of the atrium. At the minimal alt rate, it was 24%, sensor rate 75%, and sensing 95%. It's a bit surprising, 95%. Most of the time, it's either 99.8% or 0, but it's infrequent 95%. Okay, why? It's surprising to understand that there could be something like 5% of AV block. Okay, so if you click on diagnostic AIDA, okay, the AV conduction. So, okay, you see here the summary, the episode, you see the parameters, okay? And then if you click on the episodes and second degree AV block. Okay, zoom. What do you see here? So on top, it's the atrial channel, then the ventricle channel, and then the markers.
Yes, we see that there is a ventricular undersensing.
Yep, clearly. You see that if you just look at the markers, there is a diagnosis of second degree AV block. This one is blocked. It's considered blocked. This one is blocked. And if you come back at the onset of the tracing bits, and this one also is blocked. Okay, so 1, come back on the other way. 2 and 3. Okay, I don't know where it's the third one here. 1, 2, 3. it's 3 out of 12. So there's a shift from AI to DDD. Zoom, augmente un peu la valeur. As you said, what is surprising is that when you're looking at the channel at the level of the ventricle, this is actual pacing here, spike, and then there is a signal. See here? This is the entrancing ventricular activation. But what you see exactly is that when there is no ventricular sensing, it's a question of undersensing. Okay, there is one signal, but it must be the limits of the sensing capacity of this device. And you see here that there is undersensing. Okay, so that's something very important. Anytime you're going to have a shift from AI to DDD, the device will record an EGM. So first, you will have the possibility to confirm that if it is really an episode of AV block or not. And that's clearly an advantage, I would say. The only competitor with this capacity is the Boston Scientific devices. Okay, if you program the MVP in Medtronic, there is no systematic recording of an EGM when there is a shift from AI to DDD. The same for Biotronic, no recording. In Microport, there is a systematic recording, and I really strongly encourage you to systematically look at this tracing, because you will have the possibility to say, okay, this is really AV block first, and second, you will verify if it is AV block or not. And in this example, you will have the diagnosis of ventricular undersensing. Because for this algorithm, if you are actual pacing ventricular sense, you need to have correct sensing at the level of the ventricle. If there is undersensing, that systematically there's going to be a shift from AI to DDD, because the device will consider that the actual activity is blocked, since there is no ventricle because it has been undersensed. The same here, there is ventricular sensing because actual pacing is efficient. If you have a loss of actual capture, then you will have actual pacing but without capture, and therefore no ventricular sensing. So the device will consider also that this is an episode of AV block. Okay, of course. Okay, so it's clear. So with this algorithm, there is clearly an eye inside the device, and you will see things that you will not see in all the other competitors because of that. Anytime there's going to be ventricular undersensing, you will see it. Anytime you will have a loss of capture at the level of the atrium, you will see it. Anytime you will have atrial undersensing, most of the time also, there's going to be a shift from AI to DDD. So that's an help for infrequent diagnosis. Of course, if the atrial loss of capture is permanent, anytime you will interrogate the device, you will know that there is a loss of capture. But if it is really intermittent, if you lose capture on 1, 2, 3 bits, pop, you will have systematically recording of an EGM of second degree AV block or third degree AV block. Okay, something important, if you click on PM, the thing that I think is really, really interesting in Microport device is also this presentation. If you click on auto sensing, so if you click now on the R waves, please, you see this presentation here. It's on the last 2 months, every ventricular bit that has been sensed is measured. And you will see the repartition in terms of amplitude. And you see that most of the time, this is with a Gaussian presentation. You see, Gaussian presentation. Here, you see the limits of the programming of the ventricular sensing. So it has been programmed a value of 2.5 millivolt. Okay, you sense all the signals where the amplitude is more than 2.5. And you see this Gaussian presentation, and probably that here, there will be some signals, you see. When you look like this, you see that you understand why there is undersensing. Because if it is a Gaussian presentation, probably that some signals are here. But of course, this signal will not be sensed because this is the limit for sensing, okay? The program threshold for sensing, okay? So anytime I interrogate a Microport device, I have a look to this auto sensing here. So it's PM, auto sensing, and you have this presentation because most of the time you have this Gaussian present. And anytime you have a problem of auto sensing here, you will see that this is this kind of presentation with interruption of the curve because of what you have programmed. Okay, so for example, in this patient, if you click on parameter, You see sensitivity 2.5 in this patient. I will modify the sensing. I will probably not modify, you see it's here, auto sensing, monitor. I will not modify the method for sensing. I will remain on something fixed, but I will decrease the value here, 2.5, for example, up to 2 millivolt, or to optimize the quality of sensing. So decrease the value to increase the capacity of sensing. Okay, so remember, this is here, the diagnostic IDA. If you click on it, that's these things. I think I will be a competitor. I will integrate this kind of presentation in my devices because it helps for the diagnosis in many cases. So if I summarize and you come back to the parameters, in terms of interrogation, I will say it has been consistently modified in the new platform. Alizea is different. So now the duration of the battery is based on the voltage, not anymore on the impedance. Remember that once you reach the RRT, there is a systematic modification of the pacing mode and pacing rate. You can reprogram it, but even if you reprogram it, the same day at night, it will come back to VVI 70 beats per minute. So I will consider that in these devices, I change it before the RRT. In all the other competitors, you can wait for 1 week, 1 month. I don't know. If you follow this patient with remote monitoring, you can wait for the RRT and then decide to change the device. In Microport, I usually change it before the RRT, just before. Okay. In terms of parameters, the thing that you need to know is, of course, the safe R. Very important in these devices. Remember that EGM are systematically recorded, so you can verify that it works. There are some parameters that you can reprogram in terms of, in a patient with first-degree AV block, I think this is the device I will implant, because you can have the possibility to modify, require switch only at rest or during exercise. You can modify the values. And there are 4 parameters: first degree, second degree, third degree, and maximal pause. The pause can be programmed also. Another thing that you need to know, this is an old device now, but in the new ones, you can program the auto threshold at the level of the atrium and the ventricle, and then you can reprogram also the margin. But remember, this is an auto threshold, so no verification cycle by cycles of the capacity of the efficacy of capture at the level of the atrium and the ventricle. Is the same that for Medtronic. And the last point I will say will be the sensors. You have the possibility to obtain the minute ventilation and an accelerometers. But if you program the minute ventilation, then you can have the possibility to obtain information about sleep apnea. And really, without a specific leader, you can use any leads for that. So I think that's an additional information, and it can be interesting in your population of patient implanted with this device, because you may diagnose sleep apnea, and then you will require, of course, a polysomnography to confirm the diagnosis. Okay, any questions? Nope.
Yeah, just a quick question. In Microport device, is it possible to encode the lead polarity at implant? Because, for example, last week I did a box change for a patient that had an old RV unipolar lead, and I was not able to enter in the device that was a new unipolar lead. Is there a way to do it?
Leslie, are you there?
I am.
Yes. Can
In
you answer?
Alizea, we can change the way of the pacemaker is working at implant. Before Alizea, it was not possible. We have to force in the box the polarity of the lead. You program, and then you retry the head, the telemetry head, and you force the polarity. But there's no need to do that, because normally the pacemaker is able on alone to recognize the polarity of the lead. It tests the impedance of the lead, and if it cannot do the impedance in bipolar, so he stay in unipolar stimulation in unipolar. Okay.
Okay, but my question was, because it's still possible after for someone who doesn't know what he's doing to change the polarity to bipolar, for example, after implant.
Yeah, it is.
Okay.
Yeah.
Other questions? Leslie, something to add to this? Nope.
No, I think it was perfect.
Yes, Mark.
As usual.
Maybe just a quick word on remote monitoring. So in Alizia devices, I don't know if you can show it, Damien, but I don't think we.
We'll come back to the Alizia if you don't mind. Okay.
Yeah. And because it's important, just like in Biotronic devices, to activate the remote monitoring. And there are some options you can activate or deactivate, which is interesting. It's similar to Biotronic devices where you can also choose what you want to receive as alerts.
Okay, if
And
you
it's
click on parameter,
yeah,
and then remote, you see here, remote. Okay.
yeah. So here it's
usually
switched on, but you
Yeah.
need to switch it on after
Okay.
implanting a device.
Show it please off initially. So nominally it's off. So you need to switch it on. Okay. That's important, of course.
Yeah. And in the beginning, when implanting Alizia devices, is something that was often forgotten. So people had to come back to switch it on because, as you know, we're a heavy remote monitoring center. And you also need to switch on then the subsequent alerts which you need to want to receive. And of course, we want to see it all. So we switch the AF burden to on, the fast V rate during AF to on. But those are exactly the things that you need to think of switching it on. So just switching on the remote monitoring is not enough. You also need to switch on the specific alerts.
Yep. Anything else? Okay, so now that's the end about pacemakers, I will say, and we'll start the courses about ICDs. Once we'll have finished the ICD, then we'll discuss with the physicians of New York and Quebec, and we'll then discuss about electrophysiology, so ablation and all this. But first of all, next Monday, it's going to be ICD, and I think we're going to start with Medtronic ICDs. Okay, so there's no question. See you on Monday. Bye-bye.